Good evening and welcome to this unique and very special session discussing the emerging COVID-19 treatments and therapies. I am Kamal Narayan, CEO of Integrated Health and Wellbeing Council, India's premier institution for health awareness, advocacy, and behavior change. It won't be wrong to say that we Indians learned a lot about diseases and medicines in the past several months than we usually did in a lifetime. Many existing medicines were used experimentally to reduce the severity of COVID-19 viral load, while many experimental drugs were approved for emergency use to save lives. Names like ivermectin, tocilizumab, remdesivir have almost made their way to our daily conversational language. And what it signifies is the massive progress made by scientists and researchers who developed these medicines to protect us from a virus no one knew much about. The pursuit has also led to some more promising treatments. One such getting global attention is the monoclonal antibody cocktail. Whether it is a wonder drug against this infection, as it is being touted, a lot more is yet to be known about this and many other emerging treatments. But most importantly, all these therapies have become our essential weapon in the fight against COVID-19 that has infected over 21 crore people worldwide, killed nearly 4.5 million, including over 4 lakh people in India, and affected almost every person on earth. And while the most effective shield from the killer virus, the vaccines, which the world has developed at the most miraculous speed, is yet to reach all, effective treatments will play the most critical role in saving lives and limbs. As we continue to live in the possibility of a third wave of the pandemic, no matter whether it will be as disastrous as the previous ones or not, weighing our options of protective therapies is undoubtedly among the critical steps towards our preparedness for it. And to enable us with this critical knowledge and help us understand the current situation on emerging treatments, we have with us today country's top experts who are also leading the fight against the pandemic from the front. So let me welcome Dr. Randeep Guleria, Director of All India Institute of Medical Sciences, New Delhi. Dr. Guleria hardly needs any introduction. With his tireless efforts towards educating people on prevention and management of COVID-19, he has become the most trusted and relatable face at every household during this pandemic. The top pulmonologist in the country and a Padma awardee, he is also the head of the National COVID Task Force. So welcome, Dr. Guleria, to this session. Let me also welcome Dr. Dhruva Chaudhry, Senior Professor and Head Department of Pulmonary and Critical Care Medicine, Postgraduate Institute of Medical Sciences, PGIMS, University of Health Sciences, Rohtak. Professor Chaudhry is one of the key advisors of the government of Haryana in managing COVID-19 and is also a member of Lancet Commission's Task Force on COVID-19 for India. Professor Chaudhry has immensely contributed in skill reinforcement of healthcare professionals for the management of the pandemic and is also the lead author of the position statement of Indian Society of Critical Care Medicines, ICCMS, on COVID-19. And under his leadership, ISCCM collaborated with IMA for training medical professionals in ventilation and management of COVID-19 critical patients across the country. We are also honored to have with us Dr. Subramanian Swaminathan, Senior Consultant, Infectious Diseases and Infection Control, Gleneagles Global Hospital, Chennai. Dr. Swaminathan too has become a familiar face across the nation with his relentless efforts towards helping people with accurate scientific information during this pandemic. And Dr. Subramanian has a long history of involvement in academics and training. He was the faculty in the HIV distance learning course with the charge of creating the material on viral therapy as well, and subsequently consultant with the WHO and CRO. He has been involved in transplant related work, working with pioneering liver and cardiothoracic transplant teams. Also welcoming Dr. Shashank R. Joshi, Senior Consultant, Department of Diabetology and Endocrinology, Lilavati Hospital and Research Center, Mumbai. Dr. Shashank Joshi is an endocrinologist and diabetologist and medical researcher considered as one of the most prominent healthcare practitioners in our country. He is also Padma Shri awardee and is the member of Maharashtra COVID Task Force. Apart from his extensive involvement in COVID management of Maharashtra during the pandemic, Dr. Joshi is also the member of ICMR WHO Task Force for Management of Type 2 Diabetes and Director of Asian Health Clinic in Western Australia. So thank you so much, Dr. Joshi, for joining us. Last but not the least, welcome Dr. Padmanabha Shenoy, Medical Director, Care Consultant, Department of Clinical Immunology and Rheumatology, Dr. Shenoy's Care Hospital in Kochi. Dr. Shenoy has been closely analyzing the COVID-related data all along the 15 months of pandemic, has been leading the discourse of scientific management and response to the disease. He has also been aggressively working towards ensuring that rheumatic patients with weaker immunity or rogue immunity are provided with accurate information and guidance. So welcome all our very, very esteemed panelists who have spared their time from their very busy schedule to be part of this discussion. And this is important discussion because what we are going to discuss is what are the treatment options available. Vaccine has been a major shield or the protection which we look at, but keeping in mind that the pace of immunization is going on its own. So what are the options available if we get into the third wave, and especially in the states where the COVID cases are still going high? So let me begin with Dr. Randeep Guleria. Dr. Guleria, though we are going to discuss a lot about what are the preparedness for third wave, let me also rewind a bit and try to understand from you, because we have several medical practitioners also today in the audience, and they may like to understand a little bit more, from your understanding, that how has been the second wave. We as a layman saw it quite disastrous, but from the expert point of view, how did you see the second wave being different from the first wave in terms of the severity of disease or age or gender wise distribution of the cases? How would you like to share your experiences on that, Dr. Guleria?
Thank you very much, and thank you for inviting me. I think what I could say about the second wave is that what was different was the sheer rate of rise of cases in the second wave as compared to the first wave. What we saw in the first wave was that the rate of rise of cases was relatively slower, driven by the original Wuhan variant. And subsequently, we had a problem during the second wave where we initially had the Alpha variant and then the Delta variant. And this led to a huge surge in number of cases over a short period of time. And the number of cases crossed more than 4 lakh per day. And this led to a huge strain on the health system, because when you have this huge number of cases coming in one day, the management strategy gets stretched, the oxygen requirement gets stretched, hospital beds, ICU beds also get stretched. So I think it was not that there was a difference in the age group or there was difference in terms of the presentation. It was only in the factor that the virus became much more infectious and spread more rapidly among the population, the susceptible population, leading to a huge surge in the number of cases. We are now seeing that in other parts of the world also. We had surges subsequently in the UK and still having surges in the US, which is also driven by the Delta variant, which is much more infectious. So I think that was the difference. And because of that, it led to a huge demand in beds, oxygen, high flow nasal cannula, non-invasive ventilation, and so many other things, and caused a huge strain. This could be associated with a relatively higher mortality because of sudden rise of cases with limited resources which were available.
So the sudden rise and I think the higher infectivity has been, I think, the main characteristic of the second wave. I think what Dr. Guleria, you are mentioning. Let me go to Dr. Padmanabha Shenoy, because Kerala today also, in the news has shown a rise in terms of number of cases. And I think the second wave has been a little longer for them. Dr. Shenoy, how do you kind of describe the situation going on in Kerala? Is it the continuation of the second wave, or it is also a precursor for the third one?
I think it is like a piggybacking. Piggybacking, all of us have heard what piggybacking means, because one child is being carried by the mother. That's what is called piggybacking. And Kerala, what is happening currently is, over the top of the second wave, third wave is climbing. And third wave has already started mounting. The cases are rising. And last week we had the biggest celebration of Kerala Onam. Following Onam, we are expecting a huge surge. There's no doubt that there's going to be a surge. And the only question is how high it will be. The number of active cases are rising. It is now around close to 2 lakhs. And India's 57 to 60% of cases is accounted just by Kerala. This is because in the first wave and second wave, Kerala had controlled the pandemic well. So there are a lot of susceptibles. So Kerala is going to see a surge. Only question is whether we will be seeing a surge which will overtake the second wave, which when Kerala had around 35 to 40,000 cases per day. So that is the biggest question. And second thing, what is good about Kerala is Kerala's vaccination also has picked up. And around 30% of the population above 18 years is fully vaccinated. Following the vaccination drive, although the cases are rising, the hospital admissions are not rising to that extent. It is rising, but the percentage is less. Now, currently, when we saw the percentages, the ICU out of 100 2 used to get admitted previously to ICU. Now it is 1%. So definitely there is a 50% decrease. Ventilators are decreased. So Kerala can hold up to 3 lakh active cases. So even if there are some more cases, Kerala can handle. But if it goes beyond 3 lakh, 3.5 lakhs and stays for some days, active cases for some days, Kerala may be in trouble. So Kerala, I think, is going to have a very crucial 2 to 3 weeks ahead.
But I think the good part is that, as you are saying, that the vaccination coverage has been relatively higher. The number of hospitalized cases are not in proportionate to the number of cases coming from there.
It is not as high as we have seen in the second wave. It was used to be 2.5% during the second wave. Out of the active cases, 2.5% we used to get to ICU. Now it is 1 to 1.2%. So it is just half. But still, the smaller percentage of a larger number is also a large number. So if it goes to 3.5 to 4 lakhs, again Kerala may have trouble regarding the ventilators and ICU beds.
Certainly. Yeah. Dr. Shashank Joshi, a quick one from your side also. Maharashtra has also seen very extended. I think there has not been a much differentiation between the first wave or second wave, and though the numbers now are quite under control and things are getting normal. How has been your experience from both the previous waves or the much longer period of the waves in Maharashtra?
Maharashtra bore the brunt of the country probably. The first wave we had around 20 lakh cases, second wave 40 lakh cases. It's a very large number if you ask me. We still are having a thick tail of the second wave, of which it has become reasonably thin. We had around 36 districts in the state of Maharashtra. Just a month back, we had 12 districts of concern. Now it is reduced to around 5 districts of concern, which is Pune, Sangli, Satara. And we still are having around 4,000 cases being reported per day, which is a pretty high number. We have active virus in circulation. It's predominantly the Delta strain. That's where probably the Delta strain originated. We still need to be very aggressively vigilant. We are trying to aggressively vaccinate as many people as quickly as possible. But we are on the guard. The other districts are by and large out of it. Like, for example, Mumbai city, Nagpur, all the metros except Pune are out of the second wave. And we are thinking that the exposure definitely has been, because we went for early lockdown, the exposed population was a little less. And that's why we had probably got a little thicker tail. But we do have an active virus in circulation. We have a lot of population density, particularly in a city like Mumbai, migration, and now vaccination has picked up. We have a population of around 11 crores in the state, and around 5 crores at least have received one shot of the vaccine. So definitely we are much better off, and we are better prepared, both from a public health standpoint and clinical care standpoint, and in terms of healthcare capacity. So all the three things are much better prepared
Wonderful.
in terms of management and care.
Wonderful. That's quite I think reassuring to hear that from all three point of view we are prepared to kind of tackle if the similar situation emerges again. Dr. Dhruva Chaudhry, you are with us. His video is not on. So Dr. Subramanian Swaminathan, from the Chennai Tamil Nadu perspective, and also if I also see that your experience from the corporate hospitals of our country, what has been your take on the first and the second wave from the perspective of, again, the disease burden? Dr. Guleria said that the infectivity and the rapid increase was one of the major characteristics. But in terms of what's the different in terms of age, kind of distribution and gender distribution, do you see some different picture out of it?
Almost everybody who is in COVID care and has been involved in handling COVID patients has been very convinced that we've been seeing younger people with COVID in the second wave as compared to the first wave. However, if you look at the data that's been put forward from the government of India, the statistics don't seem to bear that out. And actually speaking, it's still the most vulnerable people and the elderly people and those with comorbidities which seem to be prey. But I'm wondering if there is a lot of undercounting as well. So maybe the counting has not been done correctly. And that's a concern why maybe the numbers are not really accurate. Having said that, yes, we were stretched to capacity, and at the time, and we all know how difficult it was managing numbers. And obviously, we've had to innovate. And in the second wave, we were just getting to the point where there was rationalization of treatment policies. Unfortunately, not all the pieces of the puzzle were in place before the end of the second wave, which could have made our life a lot easier if we had more pieces of the puzzle in terms of the treatment paradigm. Also, the fact that we were hit by shortages of certain critical issues, drugs like maybe tocilizumab and things like that. So obviously, in terms of inventory management, in terms of case handling, a lot of things I think could be lessons learned. And also the fact that some states got the public-private coordination much better than other states. And also it was a rude wake-up call in the fact that our bench strength in handling critical care was probably far from adequate in the country. Not just in terms of beds, but also in terms of workforce, whether it's nursing, whether it's critical care trained people. See, putting a plastic surgery fellow or a neurosurgery fellow or a gynecologist in the COVID area is a stopgap measure. But obviously, you should understand that productivity will not be the same as an intensivist at the bedside handling real-time decisions. And obviously, we need to innovate and we need to look at technology and we need to see how we can learn from best practices very, very quickly. And these are areas where I think we could take some positives and try and see how we can upscale all of that. So yes, all in all, we could have done better. But that is not to say that it was an abysmal failure. Please understand that the West is now learning to come to grips with the Delta wave. And all those people who are in the pulpit are now trying to figure out what to do when the shoe's on the other foot. So, I mean, I don't wish anybody any harm. But having said that, the fact that the viral loads are much higher, the transmissibility is much higher, the virulence is much worse, the case progression is much faster. All of these things are coming home to roost, and people are now realizing that handling the Delta wave was not at all easy. And given that we were hampered by the lack of monoclonal antibodies and the vaccines were still, a work in progress, we've done much better than it could have been. I think the only way we will know is by comparing it against the 1918 catastrophe. When you look at it that way, it just pales in comparison. Not to downplay the number of deaths that we had, but it could have been a lot worse. And I think we weathered it a little better than what should have been, but we could have done better as well. Yes.
So we could have done better, but we necessarily, or I think for sure, we need to do much better in the third wave if it anyways come our way. Dr. Dhruva Chaudhry, we saw in Kerala because of Onam, a little spike coming in North India, where you are, we have just celebrated Raksha Bandhan, Rakhi. How do you see, do you see there is some kind of possibility, keeping in mind that the adherence to COVID appropriate behavior and the mingling of people now? Do we see that possibility of some changes in the kind of numbers we see in North India as of now?
Thank you, Kamal. I heard all of them. Sorry, I was in an interview board, so just came out. That's why it took some time. But yes, you see, we know the surges have been in the Maharashtra or whether at any other places. We had super spreader events and things have come up. So I know Raksha Bandhan probably there have been a lot of rush, but not to that extent what we saw at other places. And immediately to think that it is going to cause a surge in near future, I probably will have a little question mark right now, because what we are finding is not that I'm going to be little relaxed or that taking a back foot, but primarily for the reasons that still the epidemic or the tail which has been described by Dr. Joshi also has been by the Delta variant. And most of the time what we are seeing is that a fairly large number of population has been exposed to it. And like in my state of Haryana, Dr. Guleria was also talking earlier, but in my state of Haryana, nearly 60% people have got one shot. So I think it will be, surges will be there. Punjab, we are looking very carefully. The hill stations, we are looking very carefully because our numbers have gone up. But nevertheless, I think next 2-3 weeks, having said so, I will be careful. I will not make any guess, and I will be ready for the worst case scenario to see it and pick up whether we are, because we have not reduced your testing. That is what we are going to pick up. So that is what we are continue to do for next 2 to 3 weeks. But I'm reasonably hopeful that probably things will not be bad. That I'm a little optimistic about it. And one part which I want to add to what Dr. Subramanian was saying it, you see, probably we got stuck up with the second wave. Much worse was, if we do a little bit of an introspection, was, I hope my panelists agree with me, that after first wave, we started having a very low cases. We became complacent and we thought that we have won the war without realizing the probably I can say that it was a tactical retreat by the enemy, that is the virus in this case. And we were seeing it coming up, but probably the ferocity, as Dr. Guleria said, we were not able to resist. As Dr. Joshi has also said, Dr. Guleria has also said, in terms of age, in terms of gender, we did not see any difference. And now the sero surveys are showing whether it was the elderly people or whether it was the young people or even the pediatric age group, which for first of all are significant, nearly equal amount of numbers have been affected. So I think it has been very secular in terms of affecting the population.
Thank you so much, Dr. Chaudhry. I think, yes, the popular perception has definitely been that the second wave had, more younger cases. But as the numbers say, definitely this message also.
Absolute, yes. When you look at the ratio-wise, no.
Yeah. So, sorry, Dr. Guleria, let's come to the one point which I highlighted, that the treatments are going to hold important key in terms of how we deal with the third wave, apart from the vaccination, and that is definitely, as most of the states are reporting, this is also picking up pace, and some of the states have done remarkably well. Some of them are catching up. Dr. Guleria, in the first and second wave, we saw multiple, therapies being evaluated, used, and then also some of them being dropped later on. Especially something like convalescent plasma, even over the period, which becomes so scarce for remdesivir or tocilizumab. They were also, there was a need to rationalize the use of that. Effectively, at present, what are the treatment or therapies available for COVID-19 patients, and what are the kind of different uses or recommendations for them?
So that's a long question, or has a long answer, but let me just try and be as short as possible. I think over the 18 months, our treatment strategy has evolved because we started off with a novel virus about which we really did not know much, and therefore a lot of empirical therapy and repurposed drugs were actually used. We are still using a lot of repurposed drugs rather than any specific antiviral for COVID-19. And unfortunately, a lot of investment went into vaccine development, but we did not really invest that much into research for antivirals or a drug which could have be effective against the virus. And we don't really have an effective antiviral drug which can be used efficiently as of now. Treatment strategies have evolved. We started off with drugs like lopinavir, ritonavir, which was initially there based on some data from China. Then we had hydroxychloroquine, which was also used a lot and touted a lot in the early days. All of these actually were not found to be useful in good trials. Randomized controlled trial didn't really show to be useful. The drug which really came up in a big way based on the recovery trial was the use of steroids in those patients who needed admission and who had a fall in their oxygen saturation and who were deteriorating. Subsequently, there was data for remdesivir, although again, it has been through some controversy because some studies did not show it to be very useful. There were studies which showed that it decreased hospitalization by a few days, and therefore the mortality benefit was not definitely proved. There was a tendency towards some mortality benefit, but it did not reach statistical significance, and therefore it was touted as a drug which may decrease hospitalization. But standard protocol then varied based on the treatment that was available at a given stage of the disease. What we really realized is that you have to have the right treatment at the right stage of the disease. In mild patients who have very minimal symptoms, no comorbidities or no risk for severe disease, it's predominantly a symptomatic treatment that is required, and they will improve with that. You really don't need to give too many drugs as far as antivirals or others are concerned. More recently now, we have monoclonal antibodies available, especially for those individuals who are at a high risk for developing severe disease because of age or comorbidities. It's also been now being looked at and being approved for those individuals who are at high risk and are close contacts of a COVID positive patient, or those who are admitted and don't have antibodies which have been formed in them and have moderate to severe disease. But otherwise, I think there is still a lot of debate as to the efficacy of these monoclonal antibodies with the new emerging variants, and we need more data as far as that is concerned. Along with steroids, one did realize that this is a disease which does cause a systemic effect. It causes a hypercoagulable state. It causes endothelial dysfunction, and therefore the use of prophylactic anticoagulants also came into use. Again, there was a controversy as to whether the role of anticoagulants is prophylactic or in severe disease should be therapeutic. Many individuals in many ICUs use a therapeutic dose, but there are now studies which haven't really shown a benefit between the therapeutic and the prophylactic dose as far as anticoagulants are concerned, even in severe disease. But having said that, we do lose some patients who continue to have a thromboembolic event despite being on anticoagulants, and I think the last word in this has not been said. Then we come to the cytokine storm or the hyperinflammatory response. The drug that was really touted was the anti-IL-6 drug tocilizumab. Again, a lot of debate as to its utility. There were studies which showed it was of benefit, studies which did not show it was not of any benefit. The recent trial by the WHO has shown that tocilizumab does have a benefit in a group of patients, and that is something that we've seen from experience also. So I think in a given subset of patients who go into cytokine release syndrome, there is some role of giving tocilizumab, and it does benefit. We also have another drug, JAK2 inhibitor, baricitinib, and there is data which also supports that in more moderate to severe disease in patients who are not improving, despite being on steroids, remdesivir, and having more severe disease, one could consider this. It's an oral preparation, but again, more data is required. But I think the bottom line is that you have to really be sure that you know when to give which drug and when not to give which drug, because use of early steroids in mild cases has led to problems, as we know. Giving remdesivir is really not indicated in early disease. I've had discussions with people in various hospitals, and some of them are giving remdesivir on day one, even in patients who have mild disease and are actually asymptomatic. So that also is not really indicated. Or people giving a cocktail of steroids, remdesivir, and anticoagulants on day one in patients who don't have hypoxemia and are actually at home. So I think the timing of the drugs is as important as the drugs, and that is something that we really need to push forward. But I really think that we need to invest more in research, in developing good antiviral drugs. Along with the vaccine, we need to have good drugs which are effective, which can be given easily to patients and are useful in the long run. We don't have such a drug as of now.
Thank you so much, Dr. Guleria. I think you have covered the entire spectrum. And I think the most important point is that, the right treatment need to be given at the right stage of or the time of COVID infection. But you mentioned about monoclonal antibodies, cocktail also. And I think, as you said, that while there has not been much investment in terms of discovering or innovating a drug as in comparison to what we have done or the world has done for vaccines, I think antibodies have always been considered an important route to block a certain infection or get it into the cells. So let me go to Dr. Shashank Joshi. Dr. Shashank Joshi, this particular drug has been touted as a game changer, and so much of studies have suddenly poured in. How do you see the clinical benefits of monoclonal antibodies cocktail, and especially because as Dr. Guleria also said that maybe because except for the very the critical stage or the severe stage or at the cytokine stage, most of the other previous stages there has been some kind of relevance there are studies for monoclonal antibodies. How do you see its clinical benefits in management of COVID?
Kamalji, as Dr. Guleria ji has very clearly said, that COVID is predictably unpredictable, and it is very difficult to decide treatment in isolation. It depends on the day of COVID. It depends on mild, moderate, severe, or critical. It depends upon various comorbidities and age. Monoclonal antibodies clearly have some very compelling data based on some very elegant trials, fundamentally in people who are at risk. For example, somebody has chronic kidney disease, somebody is immunosuppressed, somebody is a transplant patient, somebody has been given vaccinated but has not developed any antibodies. So in obese patients, severely diabetic or hypertensive or cardiac patients, people who have severe comorbidities, and we know that these are the patients who are likely to deteriorate. In them, if you administer this monoclonal lytic cocktail of antibodies, there could be a likelihood of saving a life. And even now they have data which has just emerged that the monoclonal antibody available in India, which is Casirivimab, has probably some impact on the Delta strain as well. But that data is very lukewarm. The recovery trial data also showed that it can be used later. But the ideal time to use this monoclonal antibody is in the first 48 to 72 hours. Unfortunately, most of our patients who land up with either Dr. Guleria or Subramanian or Dr. Dhruva Chaudhry or me, they come usually after 48 or 72 hours have lapsed. And then, the window, the best hit window is often lapsed. So there is good data now to suggest after recovery trial that it can be used up to 7 days and even up to 10 days. Initially, they said don't use it in hospitalized patients. But after the recovery data which came in, they said even in exceptional circumstances, in hospitalized situations also it can be used. So clearly, it is a reasonable treatment option. I would not say it is earth-shaking and we should avoid all these words because see, COVID, as I said, is a very unpredictable path. But it has high value science. I must say that it has trials which are published in New England Journal of Medicine, high impact journals, some high value science, and Some of us have had some very early use of this drug. Some of us have used this drug, but unfortunately, the drug came to India when the second wave was receding, and almost the cases had disappeared. But still, whatever little we have used in those vulnerable cases, whether they are patients on chronic kidney disease or patients who are having malignancies or transplants, we have clearly seen some very, very impressive results. Usually, this is actually an office drug. That means we can give it in our emergency room or casualty, and patient goes home and doesn't need hospitalization. But cost is a rate limiting step. It is of course almost 59,000-60,000 rupees a dose, which is not, I would say, is not out of reach of many people. But I think for a common man, it definitely is steep, but it saves you hospitalization. So if you look at the hospitalization cost, from that standpoint, definitely it has an impact. So I think in a subset of patients who are at risk and a risk to die, I think these monoclonal antibodies that way are important. It is like if you are bitten by a dog and you don't know whether the dog is rabid or not. We don't know whether the dog is immunized or not. What do? We go to a center and take a rabies immunoglobulin. Similar to this is like an immunoglobulin. An immunoglobulin is being injected. So we do that for dog bite every day in our day-to-day practice. And I think dogs are everywhere and dog bites are common. Similar to that for COVID, we have option. And it's a very reassuring option. So I think, but the point is we are getting a large proportion of seropositive cases now, because we are going to have people with single dose, double dose, and in the seropositivity, the data is not there. Just like Dr. Guleria ji said that in the Delta variant, the data, clinical data is not there. They have very good experimental data, but that data will also come. So I feel it is a very reasonably good option we have in the vulnerable group. And for that vulnerable group, it clearly saves hospitalization. So probably from that standpoint, it is cost effective. And even in the hospitalized patients, it could have a role. So I think it's a promising option. Beyond that, even in prophylaxis, for example, people who are caregivers, many of these patients have caregivers with them and they are exposed. And in them also it can be given. So I think there are some very exciting area, and we wish that this drug was with us when the second wave started. We would have saved many more lives. It definitely, I feel so very strongly about it that we would have saved many more lives. But nevertheless, better late than never. We have a reasonably strong option available with us, which is effective and can save lives, can save hospitalizations.
Thank you so much, Dr. Joshi. And also, yes, I picked up the game changer and all that from the international media, the way they are, kind of positioning it here. But you have tried to make it more very rational in terms of that what are the benefits and what is the time window where we must try to, utilize it. And as you have mentioned that, if it would have come a little early, we would have been able to save more lives. So let me go to Dr. Padmanabha Shenoy on this. Dr. Shenoy, you are already seeing a good number of cases in Kerala. Is monoclonal antibodies being utilized there
Yes.
in terms of, and what has been your experience in terms of, because the kind of numbers we are seeing in Kerala, definitely if other states pick up the similar kind of number, will that treatment or therapy is going to help them as well? What has been your experience?
I hope none of the other states pick up cases. That's the first thing. I hope and pray that
we all pray for that. Pray for that.
I think this will be, hopefully this will be the last wave Kerala will be seeing and will be out of the books in no time. That's what I sincerely believe. And yes, I am a rheumatologist and immunologist. So I deal with patients who are autoimmune disease, have autoimmune disease and or immunosuppressants. About immunosuppressed patients, despite being vaccinated, significant proportion of them are seronegative, meaning they don't form any antibodies. They are seronegative. So in these kind of patients, for example, we have a cohort of patients, 1,000 patients who we are being followed up. Some of them have received a drug called rituximab. Rituximab which depletes B cells. So even if we vaccinate these patients, they don't develop adequate immune response. So what we do is, most of the time, we check the antibody titers in seronegative patients, and upfront, we treat them with monoclonal antibodies. And we have found that this experience in 50-20 patients who are seronegative, experience is very satisfying, and they improve very well, and they do extremely well, because it has been shown that some of the immunosuppressive therapies are having worse outcomes when they have COVID. So in these patients, giving upfront this monoclonal antibodies certainly helps. For example, in autoimmune diseases where there are other system involvement, lung involvement, cardiac involvement, they have higher risk of complications. In these kind of patients, we use them, and thankfully, because of there were a lot of vials which were available free of cost, they have been come through donation from foreign countries and the companies. There were around 4,000 vials were available in Kerala, so a lot of our patients have benefited with that, and they have improved. Having said that, as the previous speakers mentioned, in seropositive patients, how much this antibody is going to help, we don't know. Second thing, regarding the newer variant, we need more data. But definitely, it is a good new tool in our armamentarium and definitely save lives, no doubt about it. And decreases hospitalization also. Because what Kerala is going to see is our hospital beds and ICU beds are going to be very critical for the fight against this pandemic. And what this antibody adds is really, if you give this antibody early, you can discharge the patient within a couple of hours, they can observe at home and decrease the number of hospitalization will come. Even one hospital bed is extremely important. What we have seen in the second wave, there are people who are queuing up for beds. So even if we can decrease the hospitalization by 30% or 40%, that will be a huge
benefit. So there is a lesser hospital stay and the possibility of the patient getting severe or less, and also in terms of prophylactic benefits are also there, as you said. Dr. Subramanian, Swaminathan, how has been your experience from your hospital, and what has been the outcome with the patients, and what all kind of stages you have been using it?
Yeah, so we have used a little more than 110 doses so far. And most of it has been based on the first indication, which is prevention of progression of disease. Basically, somebody comes in with early stage COVID. They're recently diagnosed to have COVID within the first maybe 5 days, 7 days. Usually we prefer them within the first 3 days, but fine. And you want to prevent them from going into severe COVID in the second week. Of the 70-something odd patients, we have not had a single patient progress to severe disease, and all of these are in high-risk patients. We are talking about people from 17 years to 79 years of age, including liver transplant, cancer, advanced HIV with the CD4 less than 100, all kinds of patients. And they've all done very well, and they've noticed a very quick improvement. Within about 2-3 days, they're almost asymptomatic and they feel significantly better. That's number one. The second group is what Dr. Joshi was talking about, the recovery trial data. I mean, off-label, we are using a much lower dose, and even in that, we are seeing a reduction in mortality. For those people who are antibody negative, if they develop severe disease, we are seeing that they are picking up very, very fast. We have used it again in liver transplant and a few other kind of patients, a little more than 30 patients so far. And we have certainly seen much better outcomes in these patients, and they do look a lot better. So I think for these two indications, we have used it. We have not yet used so far for prevention of transmission. We are still internally debating on that and developing SOPs for our own system. So as of right now, we have not started using it for that indication. But for the other two indications, yes, like I said, a little more than 110 patients with very good outcomes. And we are obviously happy with it. And like Dr. Joshi said, it could be part of a good treatment plan, which could make a big difference to the patient. No single thing is going to make or break the system. Obviously, due diligence and using all the weapons that you have at the right time, at the appropriate dose, can make a difference. And as part of that, I think the monoclonal antibody could also be a valuable addition.
Thank you so much, Dr. Subramanian, Swaminathan. Dr. Dhruva Chaudhry, Dr. Swaminathan says that in almost 110 kind of patients, and all most of the patients did not have any progression to severity in terms of disease, and also it was used in quite a variety of high risk patients also. Has there been any side effect also of monoclonal antibodies? Have you come across any of that?
You see, we have been able to use, as was pointed by Shenoy, that we got it as a part of donation, and it was on the lower end. So our experiences of around about 15 cases where the age has been, maximum age has been 93 years of age. And we have given it to 85-year also, 87-year also, and we have also used in less than 40 where we have the risk factors defined. because you can use it above 12 years and above. And now, obviously, the new indications and the questions which are also coming up is a post-exposure prophylaxis, to which Dr. Shashank Joshi talked about it. Recovery trial data, we did talk about it. But the dose requirement there, probably if I have to give it the current cost, if I go by the 8-gram one, which they have written, it will be costing around 6 lakhs, not less than that. So I think they're promising, but we need to be practical. And looking at it the way the prophylactic doses started from 7,200 has now come down to 1,200, we probably need to look at it. And mind you, this all has been coming up. Most effectivity is where the seronegativity is there, the 32%, where it reduced as a top-up to steroids. Not that it was used alone, but it was as a top-up to. So it is the first antiviral drug showing, and I personally feel also challenges the notion that only steroids will work, and quite often it is possible. And if you look at the histopathological data which has come up, that there is a persistence of a virus which is there, and later on we have seen quite a few cases which we have shared with Dr. Guleria also, is that we are seeing type 3 immune responses, people coming up like a vasculitis and other features. So there's a multiple factors which are, we are learning the immunology. As far as the side effect is concerned, we have not encountered with any infusion reactions. And in those 15 cases, I don't, but at the same time, we need to be careful, because in the way the new data which has come up, that people are trying to use it like every month, giving a shot of monoclonal cocktail in patients, especially hematological malignancies, hematological immune spray, where they've used it for a year. We need to see that quite often these antibodies do develop, because they are foreign proteins, whether the efficacy stays there or not for a long point of time, one. And secondly, local reactions have been there. We have not used anybody as a subcutaneous injection, but one of our colleagues from the US was saying they have been frustrated not because the monoclonal antibody has been there. They did not have the nurses to infuse it, so they are trying to make a home program. What Dr. Joshi very eloquently and elegantly said, that probably it is a office practice drug. I think that we need to be careful, and otherwise, by and large, results are there. But I again say that we need to at least have a data in more than 1,000 cases at one particular multiple places to show whether HI has been reducing 70% or not. We don't know whether it is a monoclonal antibody, definitely must have failed. But more important is, can we prevent development of late complication? Even the best of the data which they have shown with 24 is 71% relative reduction and 70% as far as with the current dose which we are using. And the companies have to change formulation, because if you have to give 2 shots from one, if you don't give 1 shot, if there is no second one available within 48 hours because there are no preservatives, so it will cost you 1,20,000 rupees. It is roughly half of our salary of a month. So on the other hand, if you have 2, it is 60,000. So I think it's a question of relativity. Yes, we have something in armamentarium. I give you an example. One of my residents' parents had it. Father epileptic. Mother has got, when she came to us, as very rightly pointed out, she was 8th day and has already hypoxia and was on 4 liters of oxygen. And she's just hospitalized with us 3 days back. We looked at antibody testing. It was negative. We gave it. Today she's on 1 liter. So probably we used it within the 10-day window period, but we are learning. So I can't be dogmatic about it. We are learning where our experiences are coming up. At time will tell whether it is right or wrong.
Thank you, Dr. Chaudhry. And yes, the cost factor is an important aspect. Dr. Guleria, when compared with the, because the other experts have also highlighted that if we put it in the perspective of a reduced hospital stay, sometime this cost may be, I think, worth it. What is your opinion on that, and how much is the possibility of, because this therapy is not as, I think, the standard protocol of the government of India as of now. Is it only because of the cost, which is, keeping it out of that, or there are still, kind of data needed to actually validate that whether the actual benefits are there or not?
So I can't answer that question. I'm sure it's not basically the cost, which is the factor, which is this thing. This has to be decided by the National Task Force and the Joint Monitoring Group as to what the data suggests. It's a consensus group which has experts from all specialities, and it's based on a consensus. So once if the consensus is not there, and cost is not a major issue as far as that is concerned, because that is something that would be looked at later on. But in patients who have to pay out of their pocket, it does become an issue, and therefore I think it needs to be kept in mind. But as you rightly said, it needs to be looked at in a broader perspective in terms of admissions, in terms of lives that could be saved. And I think those are also important factors which need to be built in. The cost may become much less if you're able to decrease an ICU admission for the same patient, which would add on to the cost of the ICU bed and the care that is required. And obviously, it will also have a mortality benefit. So I think that is something that one needs to look at. But you need to be able to have good data, and which is being generated. And like I said in the beginning, there is now good approval for and guides coming out as to when it should be given and when it should not be given. And I think if you look at that, it may be a very useful drug in the early stage of the disease, given in the select group of patients. The challenge is to make sure that it doesn't get used across the board for everyone, as we've seen for many other drugs which have been used in COVID. And that is always something which is the cause of concern, because sometimes then you'll end up doing more harm than good.
Yeah, thank you so much, Dr. Guleria. Dr. Shashank, just a couple of more questions on that, because I think that will benefit the audience here today, and many of them are physicians and medical practitioners. Is it equally useful in Delta variant, the monoclonal antibodies, or is there any specific study, or you would like to share some specific input on it?
So Kamalji, clearly, as Dr. Guleria also alluded to, and there is some data in experimental basis produced by the innovator, which is Regeneron and Roche, that it is effective against all variants. That's the first thing. Second thing is that the proof of the test is actually using it. Currently, whatever we have used it in India is when the Delta variant has been prevalent, and our responder rate has been excellent. I mean, we have colleagues across India here, and all of them have seen an excellent response. Having said that, as Dr. Guleria said, we need to generate some good science and data on it, which will come. I'm very certain that that data also will come, but I think I have no reason to be concerned that it may not work against Delta. There is a concern in another variant of concern, which is called as Delta Plus. And in Delta Plus, it is from AY1 to AY13. In the AY1, which is seen in UK and Nepal, we have also seen some sporadic cases in India. They said that there could be a escape to the monoclonal antibody, but that is to a single antibody, not to double antibody. This is basically an antibody cocktail. So even there, probably a monoclonal antibody may respond. But in India, the number of Delta Plus cases from AY1, AY2, AY3, which has been seen in some sporadic cases, has also been very good, because it appears that it is not as deadly as the Delta strain. So that Delta Plus probably is a misnomer, and it's behaving more like a Delta minus, but it's a very small percentage. So as the time will evolve, we will have better data. But currently, I have reason to believe that it probably will work in the Delta, but we need to have more documentation on the same. The global data and the data produced by the innovator is reassuring, and they have shown us graphs where it is worked against all the strains.
Thank you so much, Dr. Joshi. Dr. Shenoy, we have seen that steroid uses have sometimes led to the fungal infection and all that, which has been correlated with that. Do we have any other alternative to that available?
To steroids?
Yeah, steroid.
No. See, let us be very clear about the things. Steroid is a drug which has saved lots of lives in COVID. What has happened during the second wave was there was rampant misuse of steroids, and steroids were being used for everyone who was getting COVID. They were using it for, it was used in diabetics. So there was a rampant misuse, and uncontrolled sugars together ultimately caused this mucormycosis and this pandemic of mucormycosis. If you look at the world data, in other parts of the world, where steroids are used, mucormycosis is not that commonly seen. So we have to look at that also. Why only in India? Maybe there's a climate thing, but definitely there is a rampant usage of steroids which has caused with the diabetes, along with diabetes. Shashank knows how much it was misused and how much uncontrolled diabetes were there. I knew people who were sitting at home and people used to stock steroids, needle cocktail and take the first day one of COVID. People over the counter, people used to take steroids. So that's one of the major reasons why there was mucormycosis. So steroids are part of treatment once it comes to a COVID pneumonia. And if steroids do not work or steroids are not effective, that is the time, most of the time, we have paracetamol or tofacitinib or tocilizumab in the case of cytokine storm. So steroids appropriately used at an appropriate dosage with a controlled sugars under a medical supervision, they are very good drugs. Let us remember all these words: appropriate under supervision and control the sugars well. I think the risk of mucormycosis is very, very low. But the problem is prolonged course of steroids is not good. It has to be limited. It has to be under the medical supervision. That is the most important thing.
So appropriate use is important, and the misuse need to be avoided. Dr. Guleria, one more question, and this is not related to, more than the treatment now, and this question has been circulating for quite some time, especially, this is related to the booster for the vaccines. We saw that, especially our healthcare, professionals were vaccinated early in the month of January, February, and, around that. And some of the studies have shown that the antibodies generated because of vaccination have, kind of waned over the period. Is there any need for the booster vaccination for them? Though this question has been, kind of coming in multiple ways many times, but what's your opinion on it?
So I don't think we have enough data to show that there is a need for booster right now. Remember, antibodies is not the only way of giving protection. You also have cell-mediated immunity. You have your T memory cells, which will produce antibodies if there is a need for antibody production once there is an exposure to the virus. Also, I feel that we don't have enough doses to even vaccinate everyone right now, and we're looking at giving booster doses to others who probably we don't have enough evidence that it will benefit. I think we should focus on vaccinating those who have not been vaccinated as of now, especially the high-risk group. Still, many healthcare workers, many elderly, and those with comorbidities have not been vaccinated. And they are the ones who have a chance of having more severe disease and dying because of COVID-19. So instead of wasting our shots on giving boosters for where there is not much evidence, the focus should be on giving vaccines to those who will benefit from it, and by giving it to them, we may be able to save lives. So I think the issue should be to vaccinate as many individuals as possible, rather than going in for 3 shots, 4 shots, and trying different things. I think let's stick to what we know right now and focus on vaccinating as many people as we can, especially in the high-risk groups.
Sir, if we actually get into the third wave, what is the preparedness we have as of now, and what is being done additionally, since you are part of most of the things being?
There is a lot of preparedness that has been done. There are empowered groups formed by the Prime Minister's office. There is a whole group working, and since there is this whole so-called fear that the third wave is going to infect a lot of children, a lot of work has been done in creating pediatric ICUs and pediatric wards, and training for managing children and pediatric patients if they have severe COVID. That workshop is being done also by the Government of India with AIIMS and on an IGOT platform. Plus, a lot of other activities are being done in terms of oxygen plants, PSA, liquid oxygen. So there is a lot of work that has been done in the last few weeks or months. So I'm sure that there is a good amount of preparation. Although having said that, I'm not sure whether we're going to have a very bad third wave. My feeling is that if we are able to continue to have good vaccination, and looking at the Sero survey data, chances are that we may not have that many cases in the third wave.
Thank you so much, sir. Quite reassuring. Dr. Subramanian, Swaminathan, what's your reading? What is the preparedness? What we need to do in terms of preventing any further surge?
So the only way out we know is the vaccine. Unfortunately, even the best laid plans can go awry. So please understand that everybody keeps pointing to Israel and Iceland and say, listen, these are two countries which were brilliant in terms of the vaccine campaign, and see what's happening. But let's see what's happening. They do have COVID, but their hospital admission rates are very, very low. Their mortality is incredibly low. Point is that I think Dr. Swaminathan recently mentioned that we'll have to learn to live with COVID for the foreseeable future. It may become endemic, and this is what I've been worried about for quite some time. I suspect that there is no way our vaccine campaign can ramp up so fast that we can extinguish this. So I don't see COVID going the SARS way. I see it becoming more like a flu kind of situation where we have to learn to live with it. So I think instead of worrying about getting booster doses and stuff like that, let's not worry about something which we are unlikely to extinguish. Let's worry about preventing needless deaths. Point is, very important point here. If we cannot simultaneously extinguish it everywhere, your booster doses are not going to count for much because it will wane again. And the problem is that unless we vaccinate everybody at one go, we cannot extinguish it, and that's clear. Point is that it's going to keep going round and round. So let's worry about reducing mortality and mitigating that. When will the next one happen? Again, I haven't seen the Herald strain so far. The Delta Plus, like Dr. Joshi pointed out, looks more like a Delta minus, and this is what I was worried about. We were too quick to call it a variant of concern, and it doesn't look like a Herald strain. The Delta was a Herald strain which we did not pay attention to, and it gave us a solid backing, which is exactly what happened with flu 100 years ago. I don't expect another peak before December. I know there have been beautiful models which said September and October, and I think I don't agree with any of those models. I don't see a peak before December, probably later as well. And enough people have said that even if the third wave does happen, it's going to be far more gentle, and it is all up to us. It depends on how aggressively we push through with the vaccine campaign and how sensibly we comply with the regulations. See, Kerala is a beautiful example that way. They were able to mitigate it even when the vaccines were practically unavailable. If they can do it, we just have to ask ourselves why we can't do it. So obviously some amount of common sense and public participation has to come into it. And the vaccine is the most important part of it. I think it's a question of our own choice. And I think that's the reason why the risk of failure is so high.
Thank you so much. So vaccination holds the key in terms of, preventing any further surge, and not only surge, even if there is a surge, we can save much more lives because the hospitalization would be needed in much more less, I think, volume. Dr. Padmanabha Shenoy, what is your input for the, how we are going to?
I think the most important buzzword is going to be hybrid immunity. Hybrid immunity is the immunity what we acquire following infection. If somebody gets vaccinated, they are super immune. Their immunity is like 20-30% times that of the other people, and their neutralization capacity is much better. So, because in India, I think 60 to 70% of the population has already got the disease, and most of them have got a single dose of vaccine, the immunity generated is much, much higher. So, I think that immunity will last long, and I would like to agree with Dr. Swaminathan that because of this hybrid immunity itself, we will not have a huge third wave. It is going to protect us for the times to come. I think the buzzword is going to be hybrid immunity. Get an infection. If those who are infected get a single dose of vaccine itself, I think it generates an enormous amount of immunity. Our data is going to come out. We have done a study. It will be out in a couple of days.
Thank you. Thank you so much, Dr. Padmanabha. Dr. Dhruva Chaudhry.
Recording in progress.
You see, I think everybody is right at their own place. In one line I can say is that everybody is saying, hope for the best and ready for the worst. That's what I could make it out. And obviously the government is also one bitten, twice shy, and they're all working overtime in terms of preparation, in terms of, in fact, we are going for the over preparation right now. And practically, if you see, we took it casually in the first wave itself when there was some outages of oxygen, but this time, because the time period for 3 weeks was bad. But once we were able to stitch those things, put in place, everything took over. As far as your third wave is concerned, I think a lot of mathematical modeling, as you very rightly said, and I do agree with Dr. Guleria, but looking at the Delta variant presence, I think the number of people required to have some sort of the so-called immunity or the stopping the spread probably will be, instead of the initial 60 to 90%, the people who have infected and who are going to be vaccinated. And I think we started talking prematurely about the third. Dr. Guleria already has given it. What is most important for us to remember is first we have to vaccinate who have not been vaccinated. And here we are talking in terms of vaccinating people who already have received 2 shots. One. Secondly, I think we need to look from the hospital, from the policy perspective. All people are sitting here who have been part of policy and planning. Is that the persons who have got moderate to severe COVID in particular, do we need to give them vaccination after immediately 3 months or so? Can we wait? Because that will really, and second thing, as a part of such preparation is the government first reduced to 50% now to created 50% for the private sector, 25%. Now that is one big bottle chunk which is lying with the private sector and people not able to use. I know for sure for quite a few people who have invested into that and now they're finding no takers. Now because that is again a significant pool of vaccines which are there. So if we have to, that's entirely a different connotation than the part of a trial. But nevertheless, again I say we need to be careful, we need to be ready. And as I always say, the armies, they always prepared during the peacetime. So that I think the same way, what big thing which is happening is the establishment of infrastructure in the public sector hospitals, which probably will which will stand us in the coming time period. I think that is something which we are taking up. But most important, if you really ask me, predictor will be if we have a new variants as we have a Delta variant. So continuous molecular epidemiological surveillance is going to be the key. And where you find it up, pick it up and go with the public health strategies in those places. I think that is important. We need to strengthen besides in cost other institutions and where we can have NGS facilities where we can pick up the variants at the earliest. And rather than, I think, again, finally, one more word I will say is that let's stop comparing with other countries for one simple reason. India is now practically a United States of India, and there's so many small states having a population much more than Greenland gives us a very good practical example. But having said so, look at the population there. Now we have 20 crore, let's say, so many numbers in UP, in Maharashtra. So I think we should be a little practical, pragmatic, and that's what I reminded me of what was written in the Tribune yesterday. That's really it hit me when I was looking at it, and they're talking about it. Idealism without pragmatism is nothing, and similarly, pragmatism without idealism is meaningless. So probably that summarizes where we are and what we are discussing.
Thank you so much, Dr. Chaudhry. Dr. Joshi, would you like to add something? Then I'll close.
I'll be very brief. I think all my colleagues have beautifully illustrated. 3 things. Third wave likely to come between November, December and not earlier than that, unless there is a new mutation or variant of concern which becomes a predominant variant. Second, the wave is likely to be less because of the large-scale herd immunity for all its worth, for all its controversies. Third is that whatever happens, the likelihood of the burden on hospitals as well as burden on critical care units is likely to be less because of at least single dose being given to a large population, double dose being given to another large population. So I think that these are the significant takes, and a large exposure which has happened invisibly, because we know that there has been a large amount of invisible exposure also. So I think overall it is a very reassuring sign. I agree with Dr. Dhruva Chaudhry, my good friend, that India is like a United States of India. It's like a continent, and therefore we will have in the third wave geographic pockets and clusters, which will come at different times and go at different times. But if you see a city like Mumbai, see Delhi tests every day 1 lakh and they don't report more than 50 cases. Mumbai tests every day 50,000 and we always report 300 to 400 cases. So we know that we have Delta, we have Kappa and we have Delta plus. We now have genomic data. We have a genomic sequencer placed at Kasturba Infectious Disease Hospital. We clearly know that we have some degree of endemicity of COVID in Mumbai. Clearly that data is there because it's just not coming down. Beyond 300, we are not able to get it down. So we have realized some degree that we have to live with COVID. It will become like another disease like H1N1, flu, malaria, dengue. We will also have COVID and we'll have to learn to live with it. Only thing is these learning curves have been tough. And I think the panic buttons, my biggest worry is that it is not the pediatrics which I'm worried about. If at all the third wave hits us with a different variant, It may hit on variants in slum areas which have probably lost some degree of immunity and they have not got vaccinated. For example, classically, you will see the stress test was Dharavi. In the first wave, Dharavi was flooded with cases. The first wave immunity lasted them in second wave. In second wave, despite of the ferocious nature of the Delta variant, Dharavi did not report a single day more than 10 cases or 15 cases. So therefore, there was some degree of herd immunity in the largest slum of Asia, which was Dharavi. Our worry is now Dharavi vaccination is poor. If we can't ramp up that vaccination strategy there, then that is going to be a likely possibility that if a third wave breaks out there, we might have a challenge there. But this is an interesting learning time. India is definitely far better prepared, and probably, as one of our group members has said, probably a little over prepared for the next wave. And it will keep us, the unpredictable nature of COVID has taught us a lot of lessons. The only thing is now our current goal is to save every life, and monoclonal antibodies have assured us that if you use them early, that's a good ray of hope for us. Vaccines definitely are there, but my last point is the strongest vaccine, strongest monoclonal antibody is double masking. I don't think there is any substitute to that. There is no substitute for not adhering to COVID appropriate behavior. You may see Wimbledon, you may see Wembley match or Olympics, but as far as India is concerned and Delta is concerned, please double mask.
Thank you so much, Dr. Shashank. You have very well summarized the whole session. And thank you all the speakers who joined us today and from their very hectic schedule. And we are very thankful and our deep gratitude for that. We have been getting so many questions from the attendees, and we tried to cover some of them, but we will like to share those with you on mail, and you may like to answer, which can be sent to them as a return letter. Thank you so much, all of you. And as Dr. Joshi said, and as Dr. Guleria has been highlighting always, that the third wave also depends on how we are going to behave. Double masking is going to be a very, very important tool, which is I think the most democratic way in terms of everyone has that. We can prevent a third wave or any disastrous further wave of COVID-19. Vaccination is going to be important. So kindly and please, make sure that everyone and whom in your family and in your network gets vaccinated. Thank you so much for joining today on this program. We look forward to see you again in some next discussions related to health of the people. Thank you so much.